Let's go over the warm-up review. First question, which structures are derived from the pharyngeal pouches? So the first pharyngeal pouch is where we get the mastoid air cells in the middle ear cavity and also the eustachian tubes. The second pouch is the lining of the palatine tonsil. The third pouch is the thymus and the inferior parathyroid glands. And then the fourth pouch is the superior parathyroids. Next, which structures run through the cavernous sinus? So you have the oculomotor nerve, which is cranial nerve 3, the trochlear nerve, which is cranial nerve 4, the abducens nerve, or cranial nerve 6, the ophthalmic nerve, which is the first division of the trigeminal nerve, cranial nerve 5, the maxillary nerve, which is the second division of cranial nerve 5, and then also the internal carotid artery. Last question, what are the clinical features of osteogenesis imperfecta? So you're going to see brittle bones and multiple fractures, blue sclerae, dental problems, and possibly hearing loss. All right, let's move on to the lecture.
You know, there's nothing really funny about beta blockers. Hello everyone and welcome to our step 1 video on sympathetic inhibition. Let's get going. Okay, so in our last lecture we talked about sympathetic activation. Let's do a super rapid review. So in sympathetic nervous system we have short preganglionic fibers stimulating nicotinic receptors on ganglions that are very close to the spine, and then very long postganglionic fibers that secrete norepinephrine that are going to stimulate those adrenergic receptors, and that's going to be right on those effector organs. Now we had 4 very important adrenergic receptors. Remember those? It was alpha 1, alpha 2, beta 1, and beta 2. Now remember that alpha 1 caused an increase in peripheral resistance and increased bladder sphincter tone. Alpha 2 inhibited norepinephrine released on the presynaptic neuron. Remember, it's causing that negative feedback back on itself. And then beta 1 increased heart rate and contractility. Beta 2 caused mild vasodilation, and then more importantly, bronchodilation. Now the drugs we talked about vary depending on their effect on each one of those receptors that are found in the different concentrations throughout the body. So now we're going to inhibit the sympathetic nervous system, and just like the mimetic drugs, these drugs will act depending on their effect on the specific adrenergic receptors, and we even refer to them as such. So there are alpha blockers and there's beta blockers, and a couple of others that really don't exactly fit into those categories. So first let's talk about the alpha blockers. Remember that alpha 1 receptors maintain our vascular resistance, and then they also act on the urinary sphincter bladder tone. So if you block them, we should expect to decrease our blood pressure and then also relax the bladder sphincter tone. Now alpha 2 receptors tend to decrease norepinephrine release, as we mentioned before, that negative feedback, and the alpha blockers are divided into drugs that are non-selective, meaning they block both the alpha 1 and the alpha 2 receptors, and then there's also the selective agents that only block alpha 1. Now, the more commonly used medications are the selective blockers, and they include things like prazosin, doxazosin, and terazosin. Now, since they block alpha 1, they tend to decrease blood pressure. Now, clinically, though, they're probably used more often for their effect on that bladder sphincter relaxation. Now, specifically, they're used in men with benign prostatic hyperplasia, or BPH. Now, their side effects include postural hypotension. So when they stand up, they kind of drop their BP real quick and they can pass out. And that certainly makes sense because these drugs, again, will reduce peripheral resistance. Now also you'll see some reflex tachycardia, and again that makes sense because your body senses a lower peripheral resistance. It's going to tend to react by increasing that heart rate to compensate. Rebound hypertension is also a concern when you stop these medications abruptly. Now there's one other alpha 1 selective drug that I want to touch on, and it's tamsulosin. Tamsulosin is an alpha 1 antagonist used to treat BPH by inhibiting smooth muscle contraction, so nothing different there. So just like your Zosyn drugs, but this one is selective for something more specific. It's called the alpha 1AD receptor, and these are found primarily just in the prostate. So it relaxes that smooth muscle in the prostate region, that urethral smooth muscle, so that urine can pass more easily. It does not relax the vascular, what we call the 1B receptors as much. So tamsulosin is not going to lower your blood pressure as much as those other kind of typical alpha-1 blockers. So patients with BPH and high blood pressure maybe go with one of those Zosyn drugs, those first drugs we talked about. If they don't have high blood pressure, then maybe stick with tamsulosin so it doesn't affect them as much. Now, the non-selective alpha blockers are not used clinically that often. The examples of these are going to be phenoxybenzamine and phentolamine, and they're used in the diagnosis and temporary treatment of pheochromocytoma. Now, since we don't see that very often, we don't have much use for these drugs on our day-to-day basis. Now, one of the reasons we use phenoxybenzamine is because it irreversibly binds to the alpha-1 receptor, and even very high levels of catecholamines, like what we do see in that pheochromocytoma, they're unable to stimulate those alpha receptors at all. So the next class of sympathetic inhibitors are our beta blockers. We use these all of the time. And again, we have a few subgroups depending on which receptors they're inhibiting. First, we have the non-selective beta blockers, which are, as you can probably guess, blocking both beta-1 and beta-2 receptors. And these include drugs like propranolol, timolol, and nadolol. And then we have our cardioselective, or what are also referred to as the beta-1 selective blockers, and they include metoprolol, atenolol, and esmolol. And as the name implies, they're just going after the heart. They're just doing beta-1. And there actually aren't very many clinically usable beta-2 selective blockers. There's just no reason to have those. Now, there are two unusual beta blockers. They're called acebutolol and pindolol. They are actually very weak agonists. They're not technically blockers at the beta-1 and the beta-2, but because they are so weak, clinically they actually act as blockers because they're blocking the much more potent effect that norepinephrine or norepinephrine would have on those same receptors. So it's just kind of getting in the way. Now, you would consider using these in patients with hypertension that maybe also have problems with bradycardia. So these don't actually cause much of a decrease in heart rate. Now, there's another unusual beta blocker named nebivolol. So nebivolol is a selective beta-1 blocker, which isn't all that exciting, but it also stimulates endothelium-derived nitric oxide-dependent vasodilation. So for nebivolol, remember beta-1 blocking, and then you're also getting this nitric oxide action, and it's causing vasodilation in the periphery. And then finally, we have another kind of weird one, hybrid alpha-beta blockers. These include things like carvedilol and labetalol. They block at alpha-1 and beta-1, so you get the regular beta blocker effect, but you also get that really nice peripheral vasodilation as well. Now, beta blockers are used quite often to treat hypertension. Also, by blocking beta-1 receptors, you slow the heart and decrease contractility, and thus decrease the overall work of the heart, which is highly favorable with patients with coronary artery disease. So you'll see these drugs used in patients with angina, hypertension, and in patients after a myocardial infarction. Now, beta blockers can slow the progression of congestive heart failure, but you must also be careful in patients in a CHF exacerbation. So in an exacerbation, that poor contractility might lead to fluid retention, even pulmonary edema, a lot of shortness of breath. Using a beta blocker in this situation will decrease contractility more and even worsen that CHF. Now, less commonly, beta blockers are used to treat patients with symptomatic hyperthyroidism, or in the very rare but very serious thyroid storm. Sometimes we use them for migraine headaches, especially for prophylaxis, even for anxiety. I have a patient who uses propranolol when they have to give a speech in front of a group of people. It keeps their heart rate down. So we've established that by blocking beta-1, we decrease the heart rate, and this is also going to achieve this by slowing the SA and the AV nodes. So you can use this in patients with a supraventricular tachycardia. However, it also becomes a major side effect as well. So when prescribing these medications, you can certainly cause bradycardia, which can lead to lightheadedness and even syncope. Now, one not so obvious clinical usage of beta blockers is in glaucoma. Beta blockers, when used topically in the eye, things like timolol, nadolol, they can actually decrease the production of aqueous humor. Another use for beta blockers is aortic dissection. So beta blockers are the antihypertensive drug of choice in patients with an aortic dissection, that is if they survive. So in aortic dissection, the high blood pressure is causing that dissection or that tearing between the two layers of the aorta. So you need to lower the blood pressure to prevent this from getting worse, but you don't just reach for any old drug. You typically reach for that beta blocker because beta blockers not only decrease the blood pressure, but they decrease kind of the slope of the rise of the blood pressure. So it's not just the high blood pressure that makes that aortic dissection worse, it's that rapid increase in blood pressure during each beat of the heart. So that's why beta blockers, again, antihypertensive drug of choice for the treatment of aortic dissection. All right, so next let's talk about some of the adverse reactions with our beta blockers. Probably one of the most important adverse reactions with beta blockers is with bronchoconstriction. So this is primarily with the non-selective beta blockers that affect both beta 1 and more specifically that beta 2. That's where you're going to get the bronchoconstriction with beta 2. So if a patient has asthma or COPD, then you probably want to avoid those non-selective beta blockers like propranolol, timolol, and nadolol. And you still need to be careful even with our selective one once you get to higher dosages. Next, beta blockers can decrease glycogenolysis and glucagon release. Therefore, diabetic patients on anti-diabetic medication may be actually at a higher risk of hypoglycemia. Personally, I don't see this very often. Probably more importantly is that beta blockers prevent many of the symptoms associated with hypoglycemia. So when a patient gets hypoglycemic, they get shaky, they can get kind of tachycardic, maybe even confused or anxious feeling, and they can get real sweaty. Beta blockers actually prevent many of these symptoms from happening. Therefore, patients can get even more hypoglycemic and then really not even know it. Now, patients still get sweaty because, as we learned, sweating is stimulated through those muscarinic receptors, not by adrenergic receptors. Now, another point I want to make about beta blockers is when dealing with cocaine, another problem with beta blockers. If you have a patient who comes in with cocaine overdose, maybe they're having a lot of tachycardia, a lot of hypertension, you might want to give them a beta blocker, right? That makes sense. Let's drop that blood pressure. Well, the answer is no. We don't want to give these patients on cocaine a beta blocker. Well, why is that? Well, cocaine is going to cause stimulation of all the adrenergic receptors, not directly, but indirectly. It's going to reduce the reuptake of the monoamines like dopamine, like norepinephrine, like epinephrine. So you just got a ton of that stuff going around. So all of these are going to be acting on all of the adrenergic receptors, alpha 1, alpha 2, beta 1, beta 2, all of them. And remember, it's that beta 2 that's going to cause vasodilation a little bit. It's going to help to sort of kind of temper the hypertensive response of cocaine. So if you give a patient that's on cocaine that beta blocker, you're going to see that stimulation of alpha 1, and that's going to raise their blood pressure. But it's also stimulating beta 2, and that's going to help reduce the blood pressure just a little bit. Well, if we, again, give that patient a beta blocker, it's blocking the beta 1, it's blocking the beta 2 response, and all you have left is unopposed alpha 1 agonism. So you might actually have an increase in the blood pressure when you give a beta blocker to a patient who's already on cocaine. Instead, what are we going to do? We're going to use things like benzodiazepines, maybe even phentolamine, that alpha blocker, to help calm down that sympathetic stimulation in a cocaine overdose. Now, another potential problem is that if you abruptly stop a beta blocker, you can get rebound tachycardia, you can get rebound hypertension, or even arrhythmia if you stop them abruptly. Now, you may have heard that beta blockers cause erectile dysfunction. Now, recent studies have actually found this to be less common and really not all that true. So let's think about that. What controls erection? Remember, there's a mnemonic, point and shoot, for parasympathetic and sympathetic, dealing with erection and then ejaculation. Erection is initiated by the parasympathetic nervous system. So how can we inhibit an erection by inhibiting a receptor in the sympathetic nervous system? Well, you probably can't. And some studies have guessed that this may be a placebo effect because men have been told that beta blockers can cause ED. All right, guys, it's time for another Lewis notes. Let's see if we know which category each beta blocker belongs. All right, hello everyone. Welcome to another Lewis notes. We're looking at our beta blockers, and we're going to put all these into categories because they all end in all or lol. So sometimes it's hard to know what type of beta blocker you're actually dealing with here. So we got all of our beta blockers in the middle. We're going to move them into classification. So first one, atenolol. Atenolol is a selective beta 1 blocker. We're going to use that for hypertension. Great, it's not going to get those beta 2s. Timolol. So timolol is actually used as a glaucoma drug. It's one of those topical beta blockers that we use. Metoprolol. Metoprolol used all the time. One of the most commonly used beta blockers, and that's going to be a selective beta 1. Labetalol. Labetalol is a great one. It's one of those great alpha beta blockers, so it's kind of getting both the peripheral vasodilation, also blocking that regular beta 1 as well. Esmolol. Esmolol, another great medication. It's another selective. It's also very short acting. That's kind of its claim to fame. Next, we have propranolol. Propranolol is a non-selective beta blocker. You can use it for things like hypertension. Sometimes you can use it for essential tremor and even for some anxiety. Acebutolol is another one of these partial agonists. So partial agonists, sometimes they don't get used all that often, but when you do use them, you might use them in someone who already has maybe a low resting heart rate or some bradycardia issues. Carvedilol. Carvedilol is an alpha beta blocker, just like labetalol. Next, we have nadolol. Nadolol is another glaucoma drug, so we're going to use that topically. Nebivolol is all in its own category here. Remember, nebivolol is the one that has that beta-1 blockade, but it also has that nitric oxide vasodilation as well. And then our last one is pindolol. Pindolol is another one of those partial agonists. It's going to act essentially as a beta blocker because it's bind to those receptors, but very, very weakly. All right, so those are going to be all of our beta blockers, and if you know them in their categories, I think that'll help you a lot. All right, so next I want to talk about a couple of drugs that are not antagonists like our previous medications, but they are often used in hypertension. There are, again, as I said before, agonists. Specifically, we're talking about alpha-2 agonists. Now remember that alpha-2 receptors are located on the presynaptic neuron, and they act to inhibit norepinephrine release from that same neuron. Now the two medications are clonidine and alpha-methyl-dopa. Now we covered clonidine a little bit in the last lecture. Overall, these medications are acting centrally and are decreasing sympathetic tone. Remember, they decrease the release of norepinephrine from the presynaptic neuron. Clonidine can be used in the outpatient setting when the patient is maybe having malignant hypertension. You can give them clonidine orally in the clinic, and it's actually going to work relatively quickly. I generally don't like doing this too often because one of the unfortunate side effects of this medication is rebound hypertension. So you may have improved that blood pressure in the office, but a few hours later that blood pressure may go even higher than it was in the first place. Now clonidine is sometimes used as a sedative, and again that makes sense because it's decreasing the overall sympathetic tone in the body. Now methyl-dopa, again, not used very often for hypertension by itself. Sometimes it's more like third or fourth line if you're having problems with other medications, but it is still sometimes used in pregnancy-induced hypertension. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. I want you to try to answer those questions on your own, and then restart the video, and then we'll go through the answers together. First question, which selective alpha blocker has less effect on blood pressure? Remember, it's that one that works on that very specific 1AD receptor. That's going to be tamsulosin. Next question, what are the common side effects of beta blockers, and which patient population should use caution when taking beta blockers? So common side effects. First, we have that bronchospasm or bronchoconstriction. So you never want to give a non-selective beta blocker to someone who has uncontrolled asthma or COPD. And in general, you probably want to use caution with all beta blockers in these patient populations. Next, beta blockers can lower the blood glucose, maybe slightly. Probably more importantly, they can mask the sympathetic symptoms of hypoglycemia. So you need to use caution when you're giving these beta blockers to diabetic patients. And then next, you can cause things like bradycardia, you can cause AV block, and they can depress myocardial contractility. So you want to use a lot of caution using beta blockers in patients with CHF or patients who have bradycardia. Next, what are the various clinical applications of beta blockers? So beta blockers can be used for a lot of different things. Hypertension, CHF, supraventricular tachycardia. We use a lot in angina in MI patients. And then we're going to use some of those beta blockers in glaucoma patients as well. And then we finally have a couple rapid fire facts here. If we have pheochromocytoma, you're going to use alpha blockers. And for BPH, you're going to use a very selective alpha blocker like tamsulosin. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.